attend. Oh my gosh.
I'm a little scared.
That scared me. Okay, so anyway, good afternoon. We are so glad that you could attend our presentation today. My name is Sarah, and I am honored to be speaking at the BOM conference because it is such a great opportunity for Gabby and I.
Yes, it is. So we're so glad you could attend our presentation today. As she said before, I'm Gabby, and she's Sarah. And today we're going to be talking about the biomedical versus the biopsychosocial approaches on this interactive presentation board. You will get to interact with the slides as we move through the presentation as well. And the purpose. Oh, I see. And we are approving access. And the purpose of this board is to get you to do some deep thinking over the positive and negatives of the biomedical and biopsychosocial approaches and how this can affect the person who's being treated.
Okay, so to the next slide. What is a biomedical and biosocial approach?
The biomedical, hold on.
It's approved.
The biomedical model or approach was inspired by Louis Pasteur, his germ theory, and this is the base and foundation for Western medical practices. And its main focus is to diagnose and treat the biological ailments. But this, however, can overlook mental disorders and create body dualism, body-mind dualism.
Yeah. The bio
Psychosocial.
Psychosocial. Biopsycho serves as a philosophical and practical approach. This prioritizes the patient's experience in order to improve the outcome clinically. This can improve both their experience, care, and diagnosis. Next slide. Okay, so now let's brainstorm. So the first question for us is, which treatment would you prefer to receive?
If you guys want to put in your answers in the chat, or if you want to just brainstorm by yourselves.
Next.
Biopsychosocial, yes. You can also say what reasons you prefer this over the biomedical version. Who's waiting?
And give it a couple more seconds.
We'll give it a few minutes, yes.
Yeah. We'll have plenty of time.
Yes. Okay, so we're seeing our answers here. Dr. O said it seems to be more holistic and truly comprehensive. As we know, the body's not just a machine, and this is very important as as we have to focus on our mental health as well. That can greatly affect our physical health. And then Miss Lucy said it depends on the problem, but usually biopsychosocial. And we are more than our body.
Biology.
Yes, more than our biology. And for infections, yeah, and antibiotics. If you have something chronic going on, yeah. So both are very useful, and biopsychosocial is usually preferred because then you're able to get that one-on-one communication with your doctor where they're focused and they show care towards your mental health and what you're feeling if you're understanding and following along with their treatment for you.
Really good answers.
Yes, they are.
Okay, right, next question. So the next question is, what are some stories you have heard? So I'll give a couple minutes.
Some positive or negative experiences that you or your friend or your family member has gone through, and what might have changed their opinion on both these topics.
Deep thinking question.
Yeah, it's a very deep question. being in pain, not being heard, or helped due to biases. Yeah, stereotypes, even if you work against them, can hold a place in the doctor's mind.
Dr. O, I've heard some stories from people treated at hospitals almost like they were animals being herded. There was no care of them as humans.
Patients will adhere to medicine if they feel like they understand and why they are taking it instead of just getting prescribed something. Yep.
There's some really good stories.
Very good answers. It's pretty sad too to
It's very
have
sad.
people be treated like animals or numbers on a paper.
Mm-hmm.
Women with a serious health issue, like a heart attack, being dismissed as just anxious. That happens a lot to women. They get played down, or because they're women, or because you're going through that time, and that's not a very good approach to that. These are some excellent answers. We're going to move on to our next question.
Okay, so do you trust your doctor?
Yeah, for example, have you had some negative experiences with them? I can share one for my own. I had a doctor, we were just going for a daily visit, and I had some questions about hair thinning from stress, and she just kind of looked and she was like, "No, I don't see anything," and just continued on, and I did not trust.
I makes you feel not seen.
No, I didn't trust that doctor afterwards, and I had to change to a different one because she wasn't really listening to what I was saying. She was in such a rush to get through and go treat other patients.
And that's because it's funny because like you really trust those like the doctors because you trust what they say. You know, like if you go to trust anybody about that kind of stuff, it'd be doctors. And for them like dismissing it sometimes it's kind of like, what do I do now?
Yeah.
Kind of situation.
What else? I think men and women's important. Yep, men and women's bodies are different. Women's aren't
not just
men with different problems. Yep, because men are afraid to sometimes talk about their mental health. They feel like they just have to be strong and can't really ask their doctor these questions or have a shoulder to cry on. Another answer here is yes, and I also have just changed to a different one that here's my concern. Yes, that is excellent. You have to do what's best for you and your body, because if you're not being treated, then there's no point. And tough question. I've been misdiagnosed and took the nurse to whisper the right question. Yep, when the doctor was out of the room, sometimes it's the nurses who work a lot harder and they can see things maybe a bit quicker than doctors can, who are just popping in room to room, while the nurse has a bit more one-on-one time checking on your stats and your blood pressure and whatnot. Yes, I did. Okay. These are some excellent questions, excellent answers. I'm so sorry for these. Here in
the UK, just getting to see your GP is such a stress or struggle because the NHS is overstretched, and if you do see your GP after ages, it fees you are given the quick treatment instead of the right one.
Yeah, a lot of times doctors don't want to, or doctors, or whether or not they see what you're going through, and they just want to take the quick way out, and that does not do well in the long term. All right, excellent answers.
That was really good. Thank you all for letting us share stories.
We appreciate it. All right.
Okay, so next one.
Now, these are where we're listing the positives and negatives of both the biomedical and biopsychosocial. And I think we got a lot of that from the answers we were given before from our last question about how biomedical approach, it's useful when it comes to biology and what we're going through physically, but it's negative in the fact that there's not quite that one-on-one time where you're really telling the doctor how you feel. And then for biopsychosocial, it's personalized, but the negatives is that it may be difficult to apply. Let's go back to see if anyone wants to add to that, negatives or positives for both sides. Biopsychosocial incorporates more context than the biomedical model. Yes, that's true. Biopsychosocial, more open to hearing what the patient has to say and making it a personal and one-on-one experience. We would think biomedical would be neutral, but that's not always true. That is a fact. A lot of times, again, they treat you just like numbers on a piece of paper, and other times it's useful, but not quite as personal or one-on-one. All right. Now we're going to move on to our sticky note slide of how may this affect the person who's being treated. Now, we would have had you guys write on the sticky notes, but not everyone was able to get access. So if, again, you just want to put it through the chat and put in the negatives and positives of how this might affect you, how you would prefer biopsychosocial approach because of so and so, or prefer biomedical because it's more simple or straightforward. If you want to add anything.
See the chat.
Let's look at the chat one more time.
Oh,
there we go.
Okay, so. Oh,
yeah, you can start with the first one.
From a medical student approach, we often learn that sometimes the direct scientific approach will not work unless we account for barriers created by socioeconomic and psychosocial factors.
And Dr. said his sticky note would contain biomedical approach drives me away from seeking medical care. I don't get to the doctor because I don't get great care. That happens a lot, especially with older folks. They won't go because they feel the doctor's not really caring about what they need and just trying to give them quick medication and make them pay a lot of money. Yes, and these are some great comments. Thank you so much for still interacting with us. We're sorry that you're not able to access the sticky notes like we wanted to, but we are getting some excellent feedback and questions and answers. So thank you so much for that. All right, we'll give it one more minute. Here in Portugal, doctors don't feel like they have to discuss treatment openly with patients because they are not the authority. Patients tend to not be heard. Sometimes bosses or doctors have another boss who they're answering to, and they just tend to ignore the patient because of that, which is really sad because the whole point of doctors is to meet with them, discuss with them what you're feeling, and to get treatment for whatever it is you're going through, whether it's mental or physical. And
oh yeah. Patients be part of the team. So Dr. O, I hate it when the doctors tell me what to do without providing any background or rationale.
You have to discuss with them so that you know why you're going through, why you're doing what you're doing. You can't just be given bottle pills and just say, take this once a day for however long. Like, what is that going to do? Is that going to make me feel better? Or is this just a trial? We need patients to be part of the team. That is very, very true. Doctor-patient relationship is very important because without that communication, you're not really getting the treatment you need, and they're not providing the treatment they're supposed to be. Yep. Okay, so we're ready to move. Wait, no, we're good. Okay, we're good. Okay, so now that we're done with this presentation, I hope that you all got something out of it, whether it made you think about your personal experiences with biomedical and biopsychosocial approaches, or what you have heard about it. And thank you so much for attending our presentation. And we really enjoyed discussing with you through the chat and showing you what we've been working on. Thank you. Okay.
All right. Fabulous work, everybody. So, and it was also a pleasure to think in terms of sticky notes as somebody who was a longtime user of sticky notes but now I also wasn't destroying a lot of paper. So we need to reframe sticky notes as digital. I love that approach. Um, we've been doing our questions more towards the end, if that's okay with y'all. And so you can potentially
Okay. So, hello, this is Laura. I am so glad to everybody who is attending to this presentation. Today, I'm not going to start with a simple slide or with a definition. I'm going to start with a question that, although it may seem intuitive, poses a significant rupture with a traditional model of understanding the brain injury. This is the question: can a person mentally return to a stage of their childhood 20 years after a brain injury? Not only as a metaphor, but also as a literary device, as a clinical phenomenon, observable and certain sense structural. This question guides this research and at the same time reshapes the way we understand neurological recovery, cognitive stability, and the continuity of the identity over the time. Before entering into the clinical case and the proposed model of this study, it's essential to situate the central conceptual framework of this work, which is structured around the concept of chi storytelling in my dissertation. This concept should not be understood simply as a form or autobiographical narration, but as an active process through which the patient constitutes herself as the subject of her own experience, as is my case that we'll hear previously and later, of course. Chi storytelling, the concept, implies that the narrative is a passive reflection of life experience, but rather as a practice of agency, self-representation, and subjective positioning as well. In this process, the patient does not merely recount what happened to her, but organize, structure, and give meaning to her experience, integrating emotion, memory, and embodiment into a narrative construction that is both cognitive and affective. The term of chi, in the concept of chi storytelling, introduces an additional fundamental dimension of centrality and embodied and situate of the identity of herself, one that is not neural but shaped by lived experience, gender, and the perception of the one of the own body. In this way, chi storytelling allows us to analyze how the patient constructs the identity under the condition of neurological vulnerability, sickness as well, and how the structure of her narrative both reflect and simultaneously modulate the organization of her cognitive processes after the sickness. So from this experience, narrative ceases to be an accessory element and become a clinical and epidemiological instrument. This way, is a story is told in a fragmentation, coherence, repetition, and the silence of the patient can reveal aspects of brain functioning, and they are not always accessible through a standard in a neuropsychological test, for example, or medical test. In this sense, chi storytelling not only describes experience, but produce and reorganize the acting as an adaptive mechanism when high level the system are compromised or they don't have, for example, the patient, they don't have the diagnosis on time. This idea will be fundamental for understanding the phenomenon of late mental regression presenting in this study. So on this basis, the research is situated in an intersection between neurology, clinical psychology, narrative medicine for the patient boy, and also is based in the analysis of my two autobiographical novels, The Girl at the Mental Stop 1, and everybody can see here on the screen, and also The Girl at the Mental Stop 2, that is the continuation of the first part, that are my memoir, that they are the story of my life that we are going to hear later on. So the novels and the narrative medicine, as I mentioned before, is a proposing that approach that break the traditional separation between the subject and the object of study. Here, the life experience is not just based to be eliminated, but is as a source of knowledge which were integrated with scientific analysis and allow us to the dimension of the phenomenon that would otherwise remain invisible. So to understand the proposed model of this study, it's necessary to introduce the 4 key concepts: neuroplasticity, cognitive reserve, secondary degeneration of the traumatic brain injury, and delayed neurocognitive deficit. Taking together these concepts allow us to understand the evaluation of the brain injury is not linear, but dynamic, and also apparent functional stability may conceal underlying process of vulnerability of the patient. So the proposed study can be summarized as follows after a traumatic brain injury. An initial deterioration occurs followed on a phase of recovery by synapse plasticity and cortical reorganization. This phase may lead to a prolonged period of plasticity and apparent stability during the individual recover much of their function. However, the stability does not imply the absence of damage, but rather compensation, like a recovery. Over the time, factors such as chronic low-grade inflammation, secondary neural degeneration, for example, or stress, may progressively reduce the efficiency of the neural network that previously was working good. So leading to the decrease is like a cognitive reserve. When this reserve is depleted or compromised in a compensatory strategies, is to be effective and giving rise to the symptoms of the study, as in this case we have like the mental regression, because the key sequences can be outlined as the traumatic brain injury, the initial deterioration, the recovery, the stability, the secondary degeneration, and also the mental regression. Approximately 20 years ago, I suffered a traumatic brain injury in 2006 with a traffic accident, and I have been in a coma almost a month. So I lose all my memory and completely I don't have any past at all. So there was a functional recovery after many years, but for years after the condition of be stable, however, the brain starts changing because the brain does not end with the rehabilitation end. So over the time, the persistent change emerge in the organization of thought, developing idea, the emotion, the expression. So after this trauma experience that happened to me and the delayed diagnosis that also everybody will analyze on my research, I decided to write my 2 autobiographical novels mentioned previously, The Girl at the Mental Store, that my dissertation is based in both of them. Within the framework of Gender Genet 1972, the theory of narrative time is a distinction between the historic time, chronological time, and the story time, narrative time, as particularly are useful for analyzing not only the structure of the narrative, but also the subjective experience of the patient in a complex neurological process, as is my case study. Chronologically, the case presented in this research, Torres Caro 2023 with the first novel and 2026 with the second novel, follow apparently linear progression. In 2006 was the traumatic brain injury. In 2080, the first neurological symptoms appear on my right hand. Between the 2018 and 2022, there was a prolonged recovery, but in 2022, together with neurological symptoms, we can definitely identify the onset of the mental regression, as we can have here in this case study. Also, I would like to mention that at the present, the sensation of the tingling of my right hand reappear, and the memory, the short memory, even epilepsy. So here we see how the progression of the sickness happened. And also in 2024 was the injury on my amygdala. So the axis continue the clinical timeline of the disease progression. However, when we analyze how the experience is narrated, we observe the story time does not follow the linearity. because the narrative situates in the present and the current situation of tingling, so the past and the present. And the analepsy is activated that directly return to the onset of the symptom of 2018, continuing the intervening year. So we have here the narrative time and the history time. This reorganization is not arbitrary, but reflects how the memory and the embodied experience restructure the perception of time under the condition of neurological vulnerability. In this case, Torres-Caro and the dissociation between the chronological time and the narrative time align with the bonded model of the dissertation, where the timeline of the illness, 2018 and 22, and the currently injuries coexist with a fragmented identity, time life, in which different layers of the self emerge not linearly. And the application of the previous theories from Janet reveal the narrative structure that not merely represent experience, but act as an indicator of the possible alteration in autobiographical memory system, and also the temporal integration of the self. This reinforces the central hypothesis that the regression of the narrative fragmentation reflects as a functional disorganization of the brain network, rather than just literally quote. For example, here we are going to hear the quote of my second novel, Torres-Caro 2026, page 84. A kind of reverse brain that can, after a trauma, pushing part of me back to a younger age, as if time inside my head were moving backward. So this change did not present as a sudden loss of ability, but as a transformation in the structure of my subjective experience. Here emerged one of my central problems of this research, the confusion between mental health and brain health. For the intention, I proposed the concept in my dissertation of misduality, which point the difficulty of difference between psychiatry and neurology, especially in cases where the symptoms don't appear immediately of a clear image test, so they involve the delayed diagnosis. And many of these changes were initially interpreted within the framework of mental health. And if there were psychological or psychiatric alteration of a neurological base. However, this interpretation overlooked a fundamental issue, behavior and emotional symptoms, may be direct expression of alteration of the brain functional organization, not just as a psychological part. So also, Gringischer in 1845, it being established the mental disorder has a cerebral basis. In clinical practice, is implicit separation between the psychological and the neurological perceived, which can lead to incomplete or wrongly diagnosis. In my case, the initial absence of clear radiological finding or image text contribute to my experience of delayed diagnosis, being completely misunderstanding of the neurological origin. And this pattern is no exceptional, but reflect a structural limitation of how the symptoms following after a brain injury are completely misunderstanding and also addresses. And this is for us to ask, are we interpreting behavior of the patient or understanding the brain? And another quote that we can hear here is Torres-Caro 2026, page 81. Her amnesia not only took away her previous knowledge and aspiration, but also disdained her from her higher academic goal. So she chose teaching, since having lived a double life after coma or even a triple childhood with sudden mental regression. She could understand and work very well with children at this age for teaching them, of course. In this context, the study proposed that delayed mental regression should not be understood as a primary psychiatric disorder, but as an expression of the brain vulnerability that emerged when compensatory networks are no longer sufficient at this time. It's important to emphasize that regression in this sense does not imply a literal return to childhood, being a child again. No, it's a loss of previously acquired development. And the adult brain does not always biologically move back forward in time. What occurs is like a progressive loss of the capacity to access to a higher order function. depend on the integrated of frontotemporal and limbic network. And this network are responsible for processes such as planning, emotional control or regulation, complex of the language, and the integration of the autobiographical memory. With this network weakened, the cognitive system resort to more immediate and also less regulated form of functioning, which may externally childhood patterns. But the classical case of Phoenix Gage in 1848, and everybody here probably, is a fundamental reference for understanding the relationship between the frontal lesion and also the changing in personality and behavior. However, this case presents important limitation as the change happened to me after my accident in 2006, were immediately and described exclusively from the external perspective, analyzing the two novels, Torres Caro 2023 and 2026. In contrast, the present study introduced the absence that happened on the brain, because I am using the first person convert in the third person in my autobiographical novel for analyzing the subjective experience of a patient, and also with the use of the concept of chi storytelling. And this allows us to analyze how the behavior and the emotional chain, but also the internal experience of the disorganization of the self after a brain injury. From this central question, we are going to hear how are chronological age, cognitive development, and behavior reconcile where they appear to contradict one another. An individual may be chronological as an adult and also maintain the complex of cognitive history, and the behavior correspond with the early development of a stage. This apparent contradiction does not imply real regression, the mental regression, but is a functional completely alteration between the brain system and also the higher level of the regulative system, lost completely the efficiency and also the processing model. So from a neuropsychological perspective, we can understand in terms of the disorganization of the brain functioning as a line of, for example, following the theory of Feinberg and also Jackson and Freud about the regression as a return to lower level of the functional organization of our brain. Within this framework, regression of a mental regression does not imply that just is a complex cognitive structure. It's as a loss of access to the same function. The individual retain the cognitive story and that cannot mobilize the system of the misinterpretation. So this gave us to have the subjective experience of the patient, and also the instability and consistency of the different level of functioning of the brain. In my personal experience, this process does not manifest as a regression in the sense of returning to a childhood, but as a temporal also a perspective of herself or myself, in which different versions of the identity emerge depending on the emotional and the cognitive context. This version does not correspond to a chronological age as a mental regression of the childhood, but I want to mention that in my research is like differentiate the subjective experience with the multiple chi perspective. For that reason, I'm using the concept of the chi storytelling. So the chi perspective we can analyze in my two novels as a different way of being oneself as a woman. So it's not the loss of identity, but it's a dynamic coexistence of the self-configuration after the brain injury to be active again. And this experience find a direct correlate with the narrative production developed in the Get Out the Mental Stop 1 and 2, where she can see as a woman, so as a different perspective. Fragmentation, the time, the narrative voice, and also the emotional change and repetition of the same neurological symptoms one by one. So in this context, the narrative does not represent the mental regression in evolutionary terms, but as identity reconfiguration, in which the protagonist is in different feminine perspective or female perspective, and also is a reorganization of the cell under the condition of the neurological vulnerability after long time of period of the traumatic brain injury that happened 20 years ago. So we are going to hear now a quote of my second novel again, Torres Caro 2026, page 510, in which we analyze the chi perspective in women. She began to hear voices, blurry distance, mixed with electrical connection of her own neurons. So in this sense, narrative not only describe experience, but reproduce it, becoming as a space organization of the brain become visible. Complementary regression can be understood as an echo of a lost memory. Faced with difficulty in integrating autobiographical memory, the brain consolidates affective and cognitive pattern of a form of compensation as a recovery after the alteration. And experiences such as deja vu or memory fragmentation are not merely figure but manifestation of the system to maintain coherence of the self, of the identity, and after the condition of the limitation. In this process, narrative play a fundamental role, and it allows the articulation of the identity after neurobiological perspective. So the implication of the phenomenon here in the two novels are significant for the clinical practice as using the narrative medicine for the patient boy. And they challenge the idea of neurological recovery is a definite process and highlight the need after the long period of a traumatic brain injury. Second, they underscore the importance of distinguishing neurologically and psychiatric disorder. This type of experience highlights the importance of narrative medicine as a epistemological tool and clinical. Understanding the patient requires listening to their story and the full complexity. Recognizing the symptoms are not only biological dates, also are expression of the biography and also a transformation of their own identity. Within the framework of my doctoral research, I have explored the dynamic through my two autobiographical novels mentioned previously. So the narrative structure, the reflect of temporal fragmentation of the identity reconfiguration and the presence of voices of patients and early and late development after the misunderstanding or delayed diagnosis. So literary creation that became a space of analyzing the neurological experience of the patient and also the communication in medical consult or misunderstanding with doctor as well. In conclusion, the late mental regression should not be understood solely as a sign of deterioration. So it's also a complex process of the disorganization and also reorganization of the self. So the identity is not just a fixed structure after the brain injury. It's a dynamic construction, but the brain also reconstruct over the time and after the alteration of the brain, like neuroplasticity, everybody knows. So the integration of the life experience of patient and narrative analysis and scientific knowledge in my research propose a model that allows a deeper understanding of the transformation of the brain, because when the brain loses complexity, it doesn't disappear. It just finds new ways to reorganize itself in order to survive. Finally, the value of the narrative medicine, chi storytelling, and the analysis of my two autobiographical novels, Torres Caro 2025 and 2026, highlight as a means of accessing dimensions of experience that are not captured by traditional method of evaluation of patients. So thank you very much for listening to me today. If you have any question, don't hesitate to ask me now. And if you like also to hear more about the Get at the Mental Store 1 and 2, of course, you can follow me in social media, as I can share with you now in the chat. Is Brain Wakes Awake. And thank you very much for your time.
Thank you so much.
Awesome, thank you. Hi, everyone. My name is Zara Fatlawi. I'm a third-year medical student at Oakland University William Beaumont School of Medicine in Rochester, Michigan. And I'm really excited to listen to everyone speaking today. I've been learning a lot about the different things across the different disciplines, and I'm excited to share about the different research that I've been doing and something that I'm really passionate about. So I'll go ahead and get started. My research is focused on the visible identity, the epistemic trust, and the professional legitimacy that we can see throughout the case of women who wear the hijab. And I'll go ahead and I'll talk a little bit about that. So as we've kind of touched upon during the conversations we've had today, trust is a major aspect of the patient-physician relationship, and it's something that I'm very passionate about as someone who's going to be a physician in the next couple of years. And the trust relationship between patients and physicians can be defined in 5 different ways. It's dependent on a patient's perception of a doctor's reliability, on their professionalism, on the way that they're willing to seek care from them, and on their competency skills that a patient will perceive. So we can sometimes say trust as like a blanket term for the different things that are encompassed within that patient-physician relationship. Some areas that have been researched when it comes to trust in accordance with the patient-physician relationship have included appearance. There's some studies out there that take a look at whether patients trust a physician who is wearing their white coat, or if they're dressed in business casual, or if they're dressed in full business attire versus being dressed in kind of laid back clothing. So there are studies that take a look at that. I know another medical student that I'm working with right now, we're working on a project where we see if trust is impacted by a face mask. So there are different aspects that we are accounting for when we look at the patient-physician relationship. However, there is such a large gap in the research when it comes to the hijab. And for those of us who may not know what that is, the hijab is a headscarf that is typically worn by Muslim women across different cultures. For example, I'm wearing one right now. It's not restricted to a specific culture. Different cultures can wear it, and it's usually a sign of their devotion to their modesty or to their religion. But as it's a very telltale sign that someone is Muslim. So it speaks a lot without you even having to say or introduce yourself. For that reason, I thought that it could significantly, or maybe not, impact the way that patients might perceive their physicians. And I thought that this was something that was worthwhile to kind of explore, especially now that we see that there's increased diversity within medicine. And especially in Michigan, in the Wayne County area, there are a lot of Muslim women who are going into medicine, which is a great thing. But it's very important to kind of understand what patients are perceiving their physicians as, because that patient-physician relationship is ultimately the number one predictor of how likely a patient is to be managing their health care and how likely they are to trust that their physician can take care of them. So very important topics that I by themselves I'm very passionate about, but I kind of wanted to explore them together because they're very relevant within my own community, and I'm sure they're relevant across different states, but also some personal importance for myself as well. So kind of the main aims that I had when I developed this research was to study the impact that the hijab had on the perception of physicians. And I wanted to look at that through different lenses. So I wanted to look at the trustworthiness, the cultural competence, the professionalism, the medical compliance, and how competent patients view their physicians who are wearing the headscarf. And then more importantly, with the research that I would find and the data that I would collect, I wanted to create recommendations for both medical students and any kind of student within the healthcare field, to kind of teach them and educate them about these differences if they exist. For example, if a patient or if a student, like I know amongst my own class, sharing these thoughts with them and telling them that this is something that is relevant to me might not be something that they're aware of. And I think that when we take the initiative to point out some things that we might experience within our day-to-day, that could help us kind of collectively bond and share our experiences. And I think that helps us become better physicians and better coworkers and better colleagues to recognize the issues that some of our colleagues might experience. And then more importantly, developing recommendations for patients to feel more secure with the physician that they're seeing, whether it's someone who wears a headscarf or it's someone who doesn't. And we kind of wanted to work on that through different ways based on what the data would show. So for the survey that I sent out, I chose to do a double-blind randomized control study to make sure kind of there was no other factors that could be impacting the way that we analyze the data. So I'll go ahead and I will explain the double-blind randomized control, even if others might have had some experience with it. Basically, the researchers, so it was myself and the professor of psychology that I worked with, we were not aware of the participants who saw the videos, and the participants also did not get to select the videos that they would see. So completely randomized. For the survey, it initially started with, it was a completely anonymous survey. So there are no identifications or anything like that. So patients could feel secure to share kind of their raw experience and their perception of the video that they saw. So in the beginning of the video, we sent out questions where it was assessing a patient's current mood. We were asking about things like different dynamics of a personality, like how do you identify as somebody who's creative? Do you identify as somebody who's trustworthy generally? And we were kind of able to get a scale of the personality of the person who was taking the survey. Afterwards, we asked about their own current physician. So kind of like we did earlier with one of the other presentations, just asking like, do you trust your doctor? But instead of saying like, do you trust your doctor? We use a Likert scale, and patients were going through and assessing from a 1 to 5 point scale, whether they feel supported by their physician, whether they feel that their physician will go out of their way to do whatever is possible for them to receive the best care, and amongst other questions. So this kind of helps us establish a baseline for what the participant perceives their current physician to be. So after they moved along there, we were able to send out one of these 3 options of videos. So our control group served as a white screen, and our non-hijab option was a model who was not wearing a headscarf, and then the hijab condition was the model wearing the headscarf. And before we sent these surveys out, we made sure that there was no differences amongst the pictures. We really tried to make sure that the model was kind of posed in the same way, the white coat was showing in the same way, all of these things, all these factors to reduce any chances of difference between how a patient is seeing the physician's photo. And then above the video, there was an overlying identical video across all 3 videos of a physician introducing herself. So the script says, my name is Dr. Ellie Bennett. I'm a primary care and family medicine physician dedicated to providing the highest quality care for you. I have experience in preventative care, managing chronic illnesses, and supporting your overall health and well-being. I would be happy to provide care to you and your family members, and helping you achieve and maintain good health. So it was very important to make sure that the overlying video was identical throughout, because that reduces it reduces any chance of like a slight change in tone, or if the sentence was spoken too quickly or softly, that could also play a factor. And we know that audio might play a role in how a patient perceives a physician. So we kind of just wanted to reduce that factor, and we used the identical video across the 3 options. So that was kind of the way that we collected the data or sent out the different conditions. After they saw the video, they went ahead and they answered another set of Likert scored questions, and those questions again were assessing trustworthiness, professionalism, competence, and their compliance to medications if they were to being seen by this physician, or compliance to any recommendations by them. And again, they were rated them from 1 to 5 on a scale like from disagree to agree. And we used all of that data and compared it against each other. So I'll talk a little bit about the analysis of that. We used ANCOVA, which is an analysis of covariance. And we held the age, the gender, and any religious affiliation that the participants might have had under control. So we didn't factor that in. And the analysis of the project was done mainly by the psychologist, Dr. Mohidini, that I was working with. We also included within the survey, we got some information about the participants that we were surveying, nothing that could identify them, but we did ask for age, gender, religion, educational level, occupation, income, all of these things that they could answer to. And hopefully, so with this information, we kind of, for further projects, we wanted to have the data in case we wanted to explore it, which I will talk about in a few minutes about why that could be relevant. And then some more things about the survey. We sent it out through the networks that I have through the medical school. So it was sent to faculty, to medical students, and to anyone within the OUWB network. And then it was also posted on different social media forums. It was posted on LinkedIn for people to have access to it, and for us to ensure that our participant group reached different types of people, and it wasn't just confined to medical students. And it reached different ages and different people with different experiences, because ultimately everyone is going to be a patient at some point or has experience with like a family member or a friend who has seen a doctor. So we kind of included anybody who was over the age of 18 and who was proficient in English, because at any point some people might, or everyone will have experience with the healthcare field. So some of the expected findings and preliminary results. So we are currently still collecting survey responses. However, we started to analyze some of our data, and so far we found that the responses between the control and between the non-hijab wearing, so the physician who was showing her hair, there was no difference between the two. There was no statistical difference between those two. We're still currently factoring in the hijab condition. However, we do expect some changes to be seen within the condition of the physician wearing the hijab. And I think this is something that's important to note, because of the fact that research has shown when someone doesn't look like you, you kind of perceive them as an other. And these are all things that we've collected from the multiple types of research that we've looked at, and how patients perceive physicians through their appearance. So we are kind of expecting some similar results with that follow that overall trend. However, I'm going back to the point where we collected data about someone's religious affiliation or their occupation level. We do think that there might be an increased level of trust within Muslim patients who are filling out the survey towards the Muslim appearing physician, just because of that increased tendency to align with somebody who kind of like believes the same things as you or looks like you. So we do expect that there to be high for that area to show higher levels of trustworthiness and competence. However, for the rest, we hope to not see any differences, but we are sort of expecting it, just with currently how the public has perceived the hijab. We wouldn't be surprised to see any differences between the two. And again, some of the expected outcomes from the data, again, we'll look at the fact that this is a very public display of someone's beliefs, and it's a visual cue that tells you exactly what someone kind of like involves themselves in. So it could be a potential source of otherness to patients, and that could create some kind of maybe distrust, or could create decreased perceived competence of the physician who is wearing the hijab. Unfortunately, these are all things that we don't want to see, but unfortunately there are some biases that we might have, and sometimes they are conscious biases, and most of the time they're just unconscious. And I think the fact that we separated the surveys or separated the videos helps us to pull those unconscious biases out to see if they could potentially be playing a role. And I think so for this research, for the findings that will come out, like I mentioned, we really want to develop educational tools and awareness campaigns, because we feel that it would serve patients the most. It will help them have a better patient-physician relationship, especially if they do happen to have, if they come into the hospital and a resident physician is taking care of them who is Muslim. We would want them to feel like they can trust their physician, and having the ability to understand whether patients do feel that way or don't feel that way is the first step in understanding how can we develop tools that help patients feel that they are being taken care of by someone who has the equal amounts of knowledge that any other person does. And then furthermore, we also want to create changes within curriculum itself, within medical school curriculum, to again increase that awareness that your colleagues might be experiencing this invisible burden that you might not be experiencing, and how can you serve as somebody who is an ally to their experiences, and how can you serve as somebody who helps make these changes within the institution. So that would look like increasing the amount of examples given to medical students, or just, just making this something that is aware and available to them, because a lot of people don't know. And I think it's easy if you don't know about something that other people are facing, it could be an easy way for it not to really impact your day to day. But especially within residency programs, you really become closely knit to the people around you. And it's very important for both physicians to feel like the people that are around them, the colleagues that they're surrounded by, are aware of the invisible burdens that they might face. But it's also important for patients to feel that the physicians that are taking care of them have the skill and have the trust and have all of the tools ready to give them the best possible care, to help them. And again, I go back to the idea that patients' overall healthcare goals and their overall improvement depends on their ability to trust their physician. If a doctor tells you to take medications and you don't know why you're taking it, you don't know how to take it, you don't know any of these key details, you're not going to take your medication and your overall health is going to be impacted. And having that increased trust and knowing that the person you're sitting with and going to see is there to take care of you is such an important factor in making sure patients receive optimal health. And we talked about it earlier as well, but these are all things that are important to me, in improving the patient-physician relationship and improving the trust relationship specifically. So some concluding remarks. We know that specifically in this state in Michigan, we've created the space for Muslim females in medicine, but have we created the space for them to thrive? Have we kind of recognized that these are burdens that they might experience that could significantly lead to burnout, could lead to all of these could have these negative impacts because of the failure to be recognized? So making sure that that work is being taken care of and kind of addressing it could really help Muslim physicians and Muslim medical students. And some future studies could even potentially explore the role that healthcare workers, their view of their coworkers who do wear the hijab or the headscarf, how is that impacted by the headscarf? Do they feel like their coworkers are competent? Do they feel like they can trust them? Does the hijab play a role in that in any way? So these are ideas that we would like to further explore in the future, hopefully. And overall, we just are wanting to address the gaps of inclusivity within the healthcare field, and we want to make sure that we are constantly encouraging cultural competence, and making sure that it ultimately plays into the overall goal, which is making sure that the patient-physician relationship is the best that it can be, so that patients can heal and can have a space where they can come to their doctor, voice any concerns, and feel like their health is a priority. And then for the narrative medicine aspect, I just kind of wanted to share a couple personal reflections from my time on rotations. So like I said, I'm in Michigan, and we kind of have different areas where we do our rotations, and rotations are just when we go around, see patients, kind of, we're the student doctors, essentially. So one of the stories that I wanted to share, and something that really means a lot to me, was one time I was in Troy, which is not usually where my main rotations are. It was my very first rotation. I was on internal medicine, and I was rounding in the ICU. I was pre-rounding before my attending was there. And I was kind of walking around in the hallway going to see my patient, and there was a room next door. And a woman walks out. She's completely distraught. She's just looks like she's under immense amount of stress. And she looks at me and she says, "Are you Muslim?" And I was caught off guard. I mean, I was wearing my white coat. I will sometimes get questions of like, do I go here? Do I go there? But this was such a direct question of like, "Are you Muslim? Can you help me?" And I asked her nurse, like, "Is everything okay?" Got permission from her, obviously, to speak to the patient or speak to the family. And she told me that there was her mom had passed in the hospital bed, and they had been waiting for spiritual care to come and kind of say a prayer, but there was no Muslim there was nobody Muslim immediately that was coming, and they kind of wanted to speed along the process of, making sure her mom was being taken. With her permission, I walked into the room and I was able to pray with them. And for me in that moment, I felt a strong sense of purpose because I knew this constant thought of my headscarf could potentially make patients feel that I'm not competent or not trustworthy. These are all thoughts that I was previously thinking, but in that moment where a patient felt comfortable and felt safe enough to come to me in a moment of just extreme vulnerability meant so much to me. And it further re-emphasized the point that we are creating diverse spaces, and it's so important for people of different diversities to be in these spaces because we can impact patients so greatly by increasing the amount of people who are in medicine. And again, this goes to show that we need people who have different experiences, who have different cultures to be in these spaces. Another experience that I had that made me reflect on the role of my hijab within medicine was when I was on a pediatric surgery team, and we were getting ready to go into the OR. This was my first time working with this team, working with this specific like hospital, or not hospital, but working within this specific floor. And before going into every surgery, we have to scrub in, kind of be in the proper attire. Nothing external can come into the OR. And these are all precautions we take to make sure a patient doesn't have any risk of infection or anything like that. However, I know that my headscarf is very important to me, and I know that different hospitals have different guidelines. So I made sure to get there earlier. And I asked the scrub tech, I asked, how can I make sure that I'm okay in this room? Like, do you need me to take this thing off, or kind of like, what are the expectations here? And it made me think that these are some of the invisible burdens that Muslim physicians face in the medical system, amongst all of the other kind of hassles that residents and medical school kind of creates. This is just an invisible burden that they have to kind of solve on their own. And I mean, thankfully it went well. She kind of explained the guidelines, and I was welcomed into the room and I learned so much in that case. But the extra 10 minutes of feeling anxiety and feeling nervous of, will I kind of be in trouble for wearing this, or how will I navigate these? These are all things that I have to factor in as a medical student who does choose to wear the hijab. And then lastly, I wanted to talk about the role of mentorship. I know specifically for me, a couple of years ago when I was applying to different medical schools across the country, one of the things that I was doing, I was looking at match lists, or match lists are essentially when you go into the specialty and at a hospital where you are going to serve as a resident doctor and complete your training. And I was looking at different match lists, and I was like scanning the pictures for all of the different physicians who were wearing the headscarf, and kind of looking for that sense of like, okay, will I belong to this school? Is this somewhere where I will be able to kind of thrive, and somewhere where my concerns can be addressed, or these things like this research that I'm so passionate about can be addressed, and there's a welcoming space for me to share this very important thing to me. So for me, I know that addressing these types of issues within the medical system, and kind of making sure that patients trust physicians who wear the headscarf, isn't just something that directly involves medical students now or doctors in the future. It also influences pre-medical students, because pre-med students look into all of these things. I know I was constantly researching these topics and trying to find research, and there was nothing out there. I kind of wanted experiences to let me know that I'm making the right decision into going into this field. And I hope this research is kind of one of the few researches that out there that opens the door for both physicians, for medical students, for patients to understand that we can create inclusive spaces, and we can also create them in a way that makes patients and physicians feel like they're getting the best care, and they're offering the best care, and that their experiences will help patients. And that is all for my presentation. Thank you guys so much for listening, and I can welcome any questions.
Fabulous. Absolutely. So great, and a important view into the unconscious biases and even conscious biases, explicit biases that impact so many as they navigate health and healthcare, and ties in very powerfully with one of our student submissions earlier today. The student is working as a healthcare professional, a CNA, and was talking about, the feelings of burnout, which if you're not feeling trusted, then that's going to only exacerbate those feelings. So we have a few minutes for questions. So so far we've had pretty good success with just opening up the space. And so you're welcome, audience, to both unmute yourself, to share camera if you want, and uh, let the speakers know which person you're addressing, or are you asking a question that is for all three of our current presenters. All right. Go ahead, Richard.
Good. Thanks, Amy. Well, I'd like to thank all the presenters. I found those presentations to be just really thought-provoking. I don't typically work in this space, so it's very exciting to me. I feel like my brain goes off like fireworks. I just pasted my question into the chat also. I was wondering, or I'm so glad to hear that in your medical school training, you're working on this research project, which is centered totally in what Gabby and Sarah were talking about earlier, the biopsychosocial model. And that's kind of surprising to me. I would have guessed that that wasn't an option. And so have you had any challenges in doing this kind of research that is centered in the biopsychosocial model?
Thank you so much. I honestly find it to be the opposite. I think that within my school specifically, and honestly, even through other schools, because we sometimes do have collaborations with other schools and with like residents who get their training in other areas within the country. I find that maybe this is something that has been more recent, but there's a strong emphasis on the biopsychosocial model and on addressing those different barriers within medicine to kind of help a patient receive the best care. And especially like going through the different rotations and being on medicine floors where we're managing patients for longer periods of time, whether they're in there for sepsis or heart failure, all of these different things. I specifically remember one instance where a patient was having exacerbations with his heart failure, and we gave all the medication recommendations and we gave all of the scientific approaches to how this patient could manage their illness. But that wasn't enough to actually address the root cause of why there was so many frequent hospitalizations. And I remember my attending just sat on the chair and said, okay, tell me what is preventing you from staying out of the hospital. I would like to hear it all. And whether that's something that's going on in your personal life, whether that's something that you feel like you can't access your medications or access things that would get you to where you need to be, I want to hear it so I can help you. And I think there's an emphasis on all of those different factors because we have seen that just using the like paternalism approach isn't working. Which the paternalism approach is kind of that, like, I'm going to give you this medication, take it, and I can't give you any more information, kind of like what we were talking earlier about, like the authority. We're kind of leaning away from that approach and leaning more into patient-centered conversations and including them into their own management of their care. So that's kind of the first part of it. And then the second part of it, I honestly have not found any difficulty with this kind of research. I'm working on other projects right now where I'm looking at coronary artery disease management and the cultural barriers to receiving the optimal care that you can get. Because you can prescribe all of the guideline-directed medication treatments, but if you don't factor in that people maybe can't get to their spot, to their treatment place, or can't access their medications or can't afford it, then you're missing a key essential part of why their care is subtherapeutic. I hope that answers the question.
Yeah, that was a great answer. Thank you so much for that. And I see Libby's posted another question in the chat, so I'll pass you off to that.
Hi, thank you so much. It's really not a question. I just, I collaborate with a number of the programs across the disciplines, particularly here at USCB. I work with the nursing program and I help to facilitate simulations. And we've given tremendous consideration to the ways in which we address care for individuals with different identities and faiths, and certainly traditions that can sometimes create barriers to care. But I am thrilled to say that your presentation compelled me to give some consideration to the ways in which this should also be represented in our interprofessionalism simulations, and that's really wonderful to think about how to build out and create a more expansive and mindful simulations that help to mirror what's actually happening in the field. So thank you so much for that. I'm really, it was a wonderful presentation. Thank you.
Thank you so much. And if you ever need if you would ever like to have a conversation or anything like that, please feel free to reach out to me at any point.
Yes, thank you. Absolutely. Thank you so much.